Hi, good afternoon, everyone. Welcome to Brookings. And today's development seminar is on financing primary healthcare in India and the challenges that we face in that arena. Our main speaker today is Dr. Sumit Mazumdar. He, as you're aware, is a research fellow at Center of Health Economics in University of York. We also have with us Dr. Sisir Debnath as a discussant. And unfortunately, due to unexpected international travel delays, Dr. Laheria couldn't make it. And we have in our audience experts, scholars, practitioners, and key frontline agencies in the field of healthcare. We also have among us journalists who focus primarily on healthcare. Now, today's discussion will be focused on major challenges that India face, one of ensuring affordable, effective, and responsive health services at the primary care level. And the problem is actually confounded by the fact that most of the expenditure is actually met by out-of-pocket expenditures. So how to actually better finance so that the burden actually falls less on households. Sumit's research primarily focuses on international experiences of countries with similar health systems to inform policy in India. And additionally, he explores how Ayushman Bharat initiative can be a game changer to strengthen the public sector role in market for primary health care. And without further ado, I would like to ask Dr. Mazumdar to start his presentation. And the format will be around 35 to 40 minutes dedicated to your presentation. And Dr. Debnath will present his insights for 10 or 15 minutes, and then we'll have a Q&A session around the table.
Sure. Good afternoon, everybody, and thanks for coming for the seminar, and thanks to Prachi for inviting me here, and to Shamika as well for kind of arranging the seminar. I plan to talk a bit on the challenge of financing primary healthcare in India, and kind of a little more ambitiously added a subtitle, recognizing realities and responsive policies. So it's kind of, I'll try to talk a little bit on some of the perspective of health systems, in which why is primary care important, or why do we need to talk of primary care as differentiated from the overall health care. Talk a little bit on some of the international experiences through which different countries have approached to finance their primary care sector, and then kind of talk a little bit on the Ayushman Bharat PMJY, the AB PMJY paradigm, and how that could be a game changer potentially if different conditions and others are met. So it's a bit of just running through. So why do we need to worry about primary care, and why it is crucial? What are the key building blocks in primary care to be concerned with? Then trying to, so in a more international perspective, trying to identify if there are some sort of best buys in primary care, some kind of models or some kind of a frame in which we could think of financing primary care, and then talk on the AB PMJY. Well, for those who are practitioners or work on health and health systems, it doesn't need to be emphasized that why is primary care so primary to the whole notion of health systems. The single reason could be because primary care, in a very quick approximation, is a basis from which the health system starts. There are different definitions of primary care, and a very quick could be an affordable, convenient, comprehensive service at the first point of care, which generally accounts for the more immediate common needs close to where people stay or work. So primary care is essentially a first line but comprehensive, affordable, good quality, responsive health care. There is a lot of investment case for primary care, and this year we are celebrating last year is the 40th year of what happened. Many of you know the Alma Ata conference in 1978, where the Health for All paradigm was started, and that started a movement for primary care. And why is investments in primary care actually are critical starting point for building a robust health systems. At the same time, there are big costs of missing when countries, if primary care remains weak, then the whole healthcare system goes into a mess. There are big costs of untreated illnesses, growing, failing public health. At the other end, it is primary care not responding well, makes it very difficult for a secondary and tertiary level to work. So it's very simple. If simple needs are not taken care of, it grows in complication, takes more time, resources, efforts to solve. And it's important to note that countries with strong health systems across the world always have very strong primary healthcare systems. By now, it's common knowledge. It doesn't require to be rich countries which always have good health systems. There are countries around us. Sri Lanka is a common example. Even Kerala, the region within India, and many other countries, Costa Rica, which has strong health system, and as well countries in the Scandinavia, countries in Europe, UK. I'll talk a bit on the UK NHS. So countries which have strong health systems or aims for strong health systems has always done this through strong primary care. Primary care is embedded in the notion of universal health coverage, and primary care is also, since it is the first line of health care, is very closely intertwined with the notions of a welfare state. So the notions as primary, as in the case of education, primary education is one of the core pillars of welfare state, where public provisioning of basic human capital is warranted. So in that way, primary care is a pillar of welfareism. There are a lot of rationales. I don't need to delve on that. It's the public good externality criterion, disease prevention, public communicable diseases as well. But which is important to note, I will take this point and move ahead, is given the nature of the transitioning of the diseases, where more and more chronic diseases, non-communicable diseases are growing up, then we all know by now that prevention, health promotion, early detection are the best ways of responding to NCDs, and primary care is at the core of such a strategy. So missing primary care will actually lead to uncontrollable epidemic nature of NCDs. So it's not just a choice, it's critical to have strong publicly provided primary care. Financial risk protection for more day-to-day healthcare needs. It's important to note, and I'll come back when we talk on Ayushman Bharat, is a strong gatekeeping. Primary care acts as a gatekeeping which regulates the demand. Once if you go around the big, we are in the national capital, which has one of the best public infrastructure in the country. But you go to any of the big medical colleges, it doesn't need to be said that a lot of patients there could have been treated much behind at a much lower level. So a missing gatekeeping role of primary care can completely disturb, can completely wreck the secondary tertiary care level. So the regulating the excess demand for secondary and tertiary care is a big criteria for, big rationale for publicly provided primary care. And nowadays more of stewardship roles. We now know, like antimicrobial resistance and similar other public health crises are looming up, which a lot requires a stewardship role, a lot guidance role by the public role in primary care. There are hierarchical, I'll come into that, but so it's important to note that when I say public role in primary care, it does not always means to provide health care. There is a hierarchy of roles: inform, regulate, mandate, finance and provide. I can come to that if there are queries onto that, but which means that depending on the services, depending on the nature of healthcare, the role, the involvement can be different. Well, for it's talking to the converted, but primary healthcare in India, as it stands now, has some very stark features, which so it's predominantly has been oriented towards RCH, MCH services, with some big vertical disease control programs, some of the largest in the world: TB, leprosy, malaria. But it's important that most primary care needs are met by a highly diverse private sector, and much of it are informal, which means by people who do not have required training or license or required degrees, professional training for practicing medicine. So that's how the primary care, much of it has been made. It, depending on the state you are in India, it ranges between more than 50%, but in some states it goes to about 80% of the entire primary care. There is significant unmet need, and when you talk of NCDs, it is more appropriate that the unmet need lies in more screening, early detection, and there is a lot of, which I keep on coming saying, that the gatekeeping role is highly missing. We have been talking of a referral chain for long, like at least 40 years, but at the core of a referral chain lies a strong gatekeeping model. I'll come to the UK NHS, which we'll talk on that. But in the absence of a gatekeeping role at the primary care level, there is a lot of pressure on secondary and tertiary care with a lot of incentives. In terms of financing, it's mostly financed out of pocket, 70%. There's concern for dynamic service needs, inadequate supply side responses, because since it's right now the primary care is operating in a bit of an unregulated, uncontrolled market, so the supply side responses are not always in the right direction, which actually leads to increased cost of treatment. And at the same time, there are missing strategies for illness prevention and health promotion. It is important to note, and I will come to back at the end of the presentation, that when I talk of financing primary care, financing is not a standalone strategy for in healthcare. We people who are work on health, we always talk of health system as composed of 6 building blocks. Financing is just one of them. So financial risk protection or financing doesn't automatically follow from financing. It's closely related with how the other 5 pillars: service delivery, health workforce, information, medical products, and stewardship act among each other. I can come to that if there are specific questions, but I'll try to move into that. When talking of systems thinking for primary care financing in India, systems thinking means not talking of financing primary care in isolation, but recognizing that financing primary care actually links different other domains. For example, service delivery questions: who provides what, how? So, how do you organize service provision in such an unregulated, diverse market for healthcare? You can actually, you have a plethora of choices or lack of choices in primary care now. So who does what? We don't know. Human resources. Again, it comes back to the question, and recently I'll try to talk a little bit, but if there are questions, come back to it. The National Medical Commission, is it that NMC? Yeah, the new medical bill which has been talked about, brings back the can of worms, the MHCPs or the community health practitioners or whatever, the non-MBBS model, and how does that fit in, or what happens to that? How are they paid? What are the incentives? Drugs and equipment. how do we, what kind of models do we ensure that we are talking about NCDs? Most of these requires extended period of medication. How the price of the drugs are kept under check, under control, how to prevent irrational usage, how to promote efficient drug use, big questions. Information systems, we have been talking of electronic health records in a country of 1 billion people. Information without knowing that where person X is going for his treatment, what is being provided, it's absolutely impossible to design a system and to go for it. So, stewardship, how do you regulate purchasing, contracting, priority setting? So, this is not exhaustive. This is just trying to kind of stimulate that the complexity of how, when I talk of how do India finance primary care, what are the different of these blocks, what are the big banner questions that keeps on fluttering, which we don't have answers right now. What makes us in this way is to try to look at some kind of international experiences, how some other country in the world has responded and done with that. Well, with a little bit of bias, since I am now paid from the UK taxpayers' money, I start with the English NHS. It's no way world's best, although the British always used to believe everything of them are the best. Well, at least in cricket they are now, but the English NHS stands from what is called as, for people who are used to that, is a kind of a beverage system, where it's a tax financed system based on strategic contracts with due checks and balances. It is important to note, and I keep on saying that, is the healthcare is financed entirely through public money, but it's not provided through public providers. What is done? There is a strong primary level gatekeeping. Everybody in the UK is free to choose their own general practitioner. There is a practice, but once you choose a practice, you have to stick to it. You can change your practice, but once you have chosen your practice, you cannot go anywhere. So that bit of, and this is again a point to stick, is a starting point in primary care, and there the question of political economy and political will and how we manage it comes in, is if we do not demarcate a particular provider or facility or a practice responsible for a particular group of people, no system can move ahead. That is where they started. So, consultations are not always through medical professionals. I have been in the UK for almost 2 years. I have visited my practice at least 5 times. I have been never seen by a MBBS. But it's mainly, it is very difficult to get you seen by an MBBS professional, only when your situation would warrant that level. Otherwise, it's largely by public health nurses or other level of paramedical professionals. But then there's a cascading level where it goes from PHNs to GPs to specialists to super specialists and so on. There are fixed prescription charges, you don't need to pay anything, but for prescriptions as standard, each for the number of drugs or you have been prescribed, you need to pay a standard prescription charge. But there are several exemptions, like if you are old, if you are in college, if you are a child, or if your income is under certain level or things like that. So there are largely, but for most people you only need to pay out of pocket for dental and ophthalmic cases, although a major point for Brexit, people who have been advocating Brexit, is to expand NHS to even bring dental and eye care under NHS, which I don't know if it will be. The funding is mainly through NHS England, but it is actually the CCGs, the clinical commissioning groups. There are 211 of them across the UK. These clinical commissioning groups, roughly you can think as a little less than a district level, where each group is responsible to purchase health care from medical providers. So, there are different groups of physicians or healthcare providers, some of them even small private companies. So, they are providing the care. So, they are the one, practice is actually owned by some of them, but the clinical commissioning group receives the budget from the government, and it uses that budget to purchase care from these provider groups. Provider groups, roughly you could think of like a group of doctors or a group of doctors plus some nurses and things like that. A lot of them are Indians, by the way. The GPs are self-employed, so they are basically like private doctors, but they are paid through the commissioning groups based on certain weighted capitation is the number of patients in the area. A pay for performance component, which is very important. I can come back to it and say that. So, it is just not number of patients you see, but certain performance indicators, which is estimated at the level of the population, like disease prevalence, things like that, hospitalizations averted, strokes or some critical illnesses cured and all that. Some fixed expenses are given for the practices. The strong stewardship, local needs are prioritized, but there are big issues. There are long waiting times to get appointments. This is one of the biggest complaints against the UK NHS, which the first thing in India would be like, is absolutely impossible, because if a system is not being able to respond to a country like UK, how that could be for India. But there are, it could be discussed, and there are ways of talking to it. But now it is being proposed that under Brexit, after the Brexit has been proposed, that the budget would be increased significantly. By the way, it's way where the UK is spending 10% of its GDP on health. The NHS budget is 10% of the GDP. If you say that the UK NHS doesn't work, a country which probably we will more closely identify is Brazil. The Brazilian model, PSF, which is the program Saúde de Família, it is called the Family Health Program, which takes the crux of the old Indian idea of the A&M community health worker model. If there is one country in the world, large country, which has revolutionized the concept of community health workers, it is Brazil. And it started in 1994, is currently the single largest comprehensive community-based healthcare program in the world. There are the statistics. It started from, in 98, there was a unified health system was built. I can again talk on that if there are queries. The SUS is a fantastic system which has built a lot of data records and system of who does what, providers, recruiting providers, and contracting with drug promotion. But it's important that it is based on, Brazil is perhaps one of the first, a country of a big size, which has guaranteed healthcare as a constitutional right. So, if you cannot pay for your healthcare and you are not getting drugs or services, you can go to the court and can get, that has created some complications, but it's a country which is, and that was one of the big things started by the Lula government. So, it's basically done through family health teams, which has a constitution that has a population size, does regular home visits, screening, health promotion, early detection, provides medicine, first line of care. So, and remember, this is highly cost effective, and this had started, if you see, these are the, it first started in these regions, and if somebody are familiar with the geography, these are the far flung areas, the Amazonia region. So, you can see the whole of the most of the Amazonia, these are the hard to reach areas they first started. So, it's not that it started only with the big cities. So, it started with the municipal design, and you can see the expansion is the way the teams have expanded. There are several best practice lessons. It's linked very strongly with the social welfare program called Bolsa Familia, which many of you might know. So, it has something like our Narega, but is a more unconditional cash transfer. And numerous studies suggest that after the launch of PSF, there has been remarkable improvements in avoidable mortality, NCDs, infant mortality, hospitalizations, which is an important indicator of rationalizing the system. There has been HR challenges, a lot of doctors. So it started with the mice medicos, which has more doctors coming from Cuba and others. So I had strengthened, but so there is a bit of problem for that, but calls for more public spending. The Mexican Seguro Popular is also another scheme. Mexico is also, the important learning point for Mexico is that, and what is similar for India is, Mexico is the only middle income country, a comparable middle income country, which has an informal sector which is comparable to that of India. We have about 70%. They have about 55 to 60%. Informal, self-employed, telawala and all these kind of day earners, wage earners and all that. The Seguro Popular targeted them. And it was the old, if we go back, our old RSBY models, if the old things which were written, but similar to that, but then I don't know what happened. So they started with a more comprehensive benefit package, but as a list of interventions. So there were about 300 interventions which are covered. A person is designated to a health facility. If you go there, you get the services for free. They increased their GDP contribution by about 1%, and in about 15 years, this has led to out-of-pocket contribution falling by about 15%, which is not trivial. There are several other examples. I can keep on talking. Thailand. I'm not a big fan of the Thai model, but Thailand has a well-known illustrative UFC model. Estonia. Why I said I just learned about the Estonian model a few weeks back. What is important is when they started a primary care program, and this is how things work. In 2008, they said that by 2015, they will have X number of family health practitioners who would be allowed to recruit their patients. So a physician would say that I will take 200 patients whom I will manage for 10 years. So people apply that I'll recruit. But before doing that, what they did is they said this in 2008 and said I'll start this in 2015. What did they do in between? In their medical curriculum, they compulsorily start a family medicine program. So by the time the fresh graduates will pass in 2015, the workforce, of course you can say it's a small country, but put a model for an Indian state. So there's a way which tries to say that it links with other medical education and that market as well. Colombia, another good model, which has a subsidized kind of model. There are other countries like Turkey, Iran, having Niger is an African country which has a similar Indian primary healthcare model, but through more supply of drugs and medicines. Coming into India with these examples, and 10 minutes? Yeah. So coming with these kind of examples in India, a lot of, so what could be I think this is kind of bit important for the way I'm kind of trying to summarize. Then these are some of the key concerns, these key questions for which we need to look for the answers. Number one, what should be the primary point of care? Each one of us, and again, it's important to recognize that, and this is something which I personally believe to the intent of my heart. When I talk of a health system, reforming a health system, it has to be for every one of us. No country of these, any of these, have two systems, three systems. A system which is thought to be meant for the poor becomes poor. So it's a question of perspective that, so when I say what should be the primary point of care, It is a primary point of care for me, for the person who works as a maid in my house, or the person who is a construction worker coming to Delhi and will be staying for 6 months. So, what should be the point of care for anybody in a geographical area? There is this talk of the health wellness center model. A lot of it is, there is a fantastic document by in HSRC, Tushar knows it very well, with a lot rich guidelines of 100 pages, fantastic document. How does that happens? That looks very well on paper. How does that work? But the health wellness center model is what I call as a finance and provide model, where the government is paying for the health care, it is paying for the equipments, workers, budgets, drugs, but also providing it themselves. There are other models which in many states they have started. In Delhi, the Mohalla Clinic, for example, is in a contracted model where some kind of contracts are being used in an organized private provider groups. I don't know the specifics. Some of you will know much better of the exact examples. Is in a more capitation kind of models where it is financing through purchasing. So, but we need to decide what should be the primary point of care. The health and wellness center model, which is the primary care component of the ABPMJOI, talks of health wellness center, but they are basically the same as the sub-centers or the PHCs or the urban health posts model. So, are we sure that that has to be a comprehensive first point of care? How we rationalize that? How comprehensive would be the services offered? There is a long list now, but do we? I talk of retain and delegate. Retain means the government retaining some of the core public health functions, more of prevention, health promotion, which has the more externalities. The curative functions are more delegated to through contracting. That is what the model that goes on. How to organize financing? There is some of our friends are working on the fiscal space and costing of the Ayushman Bharat model. Is sustainability whether through general taxes? I just heard that there has been a proposal of, or whether it is started, I am not sure, of a cess for Ayushman Bharat to finance it. I am not sure it's how would that work. Contributory or subsidization, that is a big model that like contributories, it's a kind of Mexican model or many other countries where a part of the costs are being contributed by the patients and for some they are subsidized by the government through some means, some ways, and the variations across the population groups. Most of you know what are the primary care components of ABPMJV, and there are friends in the room who knows of it a lot better than I do. It's been proposed to 150,000 HWCs across the country, a lot of upgradation, some very good proposals of, for the first time, we are talking of a good essential medical lists, standard treatment guidelines, quality related outcomes, and a lot of good things. A lot of emphasis on promoting wellness through more promotion. That's something which is similar in spirit to the Brazilian model. Rationalized demand for secondary care, several institutional mechanisms proposed. These are some of the ways, but the devil is in the details, that how could it make a difference. Number one, the first difference that I am talking of the game changer, potential game changer. The first potential way of making a difference is basically through free OPD consultations, because that is the elephant in the room, that the basic primary care boils down for a day-to-day OPD care needs. When you go for your common problems, chronic problems, any problems, the first point to go, most of these days it's through a private hospital or through a private clinician. So the game changer role comes through availability of free OPD consultations. But more than that, it is by making available necessary drugs for acute or chronic illnesses across the board. Apparently, if it is not very clear, but apparently anyone can go to a primary health center today and get himself or herself treated and get the medicines that is available. But if it works the way it is proposed, then on principle it eliminates, remember, eliminates the need for private drug stores, private clinicians, because it in principle it does that, because if the model it follows, then there is nothing. In the UK or in many other countries, you can only get selected drugs over the counter. But just imagine the way it lies now, the huge diversity which rests in the drug market and the prescription drug market now. So how does that match?
I want some clarity on what you said just now. You said that this will eliminate the private healthcare providers in the chemists.
No,
What did you say?
what I'm saying is the HWCs propose that all essential medicines will be made available through the HWCs, which means that, and it is not regulating that only a particular group of people can go there for the treatment. Everybody can go. Now, everybody with the need can actually go there and get the medicines, that all the drugs they need from the health wellness centers. For those prescription drugs, the private market gets eliminated because everything is notionally available in the health and wellness centers.
For the essential drugs.
And the essential drugs are basically the prescription drugs. It is not like,
No, there is a difference there. Prescription drugs and essential drugs are not the same.
okay, I mean, I'm trying to say that, and these essential drugs are quite comprehensive. The list has about 350 compositions, which practically covers a bulk of the prescription drug segment. There could be still, but what I'm saying is the broadband statements which virtually will. So statins, for example, take an example. There will be no private market for statins, no private market for medicines for diabetes, medicine, common antibiotics. You name it, because it's all there in that 350 drugs. So, but how feasible would that be? And in this scale, it's not clear. But that's a game changer. That's what I'm saying. What I'm saying here is the potential game changer stuff that HWCs promise on paper as of now. We don't know how that goes ahead. How, at least I don't know. But the big game changer is OPD consultations are made free. Chronic and acute care medicines are available at the point of care for free for all. Because this all is very important, that PHCs notionally now doesn't restrict anybody to go there. It's not a means-based treatment. It is even like in urban areas and many cases, it is even not locationally bound.
It helps to clarify, the PHC and then CHCs never ever restricted anybody to come there. Any citizen of India is
Exactly.
Absolutely welcome since 1947
Exactly.
to come there. Nobody is restricted.
Exactly. So that's why I'm saying how big the game changer could be. That
No, the point I think
always been like
what
this.
she's trying to make is that the person still has a choice. It's my choice. If I would like to, whether you make it a sub-center, a PHC,
there are
or
only
a
two
health
reasons.
and
ma'am.
wellness
I know.
center,
Ma'am.
it's my choice whether I would like to go or I still want to go to that die in my village.
Can I please request questions to be answered later? We'll just
I'm
cover
just
this
trying to
presentation and then we'll have.
Yeah, so I can add. So what I'm saying, basically there are two reasons broadly, there are tens, two reasons why patients go for private sector for their primary care needs. Number one, doctors, number 2, drugs and diagnostics. If both of these are made available at a health and wellness center, they are in principle eliminates the need for a private market. That's a simple man on the street statement. That's nothing. If there is physicians available, all the essential drugs are available, then I can still prefer to go there. But if everything is, as an economist, I would not think that as a rational decision, because there is a physician, there is free drugs. It doesn't happen that way. Anyway, that's not the thing. Is that could be a game changer, because if that's available there is a big opportunity to introduce strong public stewardship by clinically appropriate care pathways. Number of times the health wellness center, it comes back, the care pathways. How does care pathways basically is the regimen of care, the way drugs are given, and then the report, and so the way the cascading is being done clinically is being, and that's big stewardship, because a lot of the first big thing is rational use of drugs and more question of antibiotics. So there is trying to referring, a lot of emphasis is on the quality of care framework. It proposes, and that could be in regulating the private sector by encouraging desirable incentives and rationalizing demand for secondary care. The other stewardship is influencing linked markets, as I have been saying, on the medical education market, the market for pharma and other medical equipments. A well-functioning health wellness center has a good potential for triggering positive signals to unregulated private market. At this point of time, the private market for healthcare in India is supremely unregulated. We don't know like who practices what, who is there, even basic numbers. How? First is it could reduce the demand for informal providers, who are now the first line of the informal providers are in all senses the primary healthcare system in India right now. It could reduce the demand for informal providers with the added opportunity of engaging them as this mid-level healthcare providers, which some states have piloted with. Assam has done, Chhattisgarh is trying to do, West Bengal there has been some initiatives. So this reducing the demand for informal providers is a big step in regulating the private market. Incentives to private providers to organize into provider groups, that is exactly how it started in the UK, that the private providers started to organize. Right now, the private market for secondary care and tertiary care is organized, which means it is in hospitals. But the primary market is unorganized. It is largely through individual practitioners, a private clinician, or in some cases even a drugstore. So the primary care market is very unorganized. The secondary market is more organized in the private care market, in the private care the private sector. What it could do, and that's what it has happened in many of the countries in the industrialized OECD countries, is that the primary care private providers started to organize into provider groups. A good case is the UK, and at least in urban metro areas. And you can introduce broadband provider payment reforms. I am not going into the details of it, but there are ways in which capitation based kind of payments have worked, which can still work there. How could health and wellness centers shape primary care financing? The first is progressing from a line item based global budgets to a capitation model for funding primary care centers. Until now, the PHCs and the sub-centers in India are financed, the money that goes to them are purely line item based budgets. I can explain how that works, but it's basically a budget that goes to the state government goes to the district, and through the district it goes to the PHCs in a simple line item that certain 1,000 items for each heads X amount of rupees are allocated and it's paid to the centers. But what many of the countries have done is a more capitation based, which is basically it works on the patients, the catchment area. Based on that, a sum of money has been provided to the. It's basically kind of autonomizing the PHCs or at that level where it works under, which gives a lot of flexibility and autonomy, but also is a question of capacities. Okay, sure. So it's basically establish them as more competitive entities, remunerative benefits, opportunities for contracting with private sector, and cost containment. A lot of energies on HTAs. There are examples in India, the Tamil Nadu UHC pilot in some of the primary health centers in four districts probably. Yeah, in 4 districts they have started in reforming some kind of what the HWCs envisage has been done. There are several other learning examples. I'm a big fan of Himachal Pradesh. I stayed and worked there for some time. How the primary care in public facilities is what is an important case in point. The Mohalla clinic examples, Delhi, Jharkhand, Telangana is also starting a Basti Dawakhana model. Limited experience of engaging in. So basically, these are some how you can organize primary care in through the HWCs model. So it's basically like is a potential game changer, but is critical preconditions: strong budgetary commitment, clarity in split of financing channels, how it's done. There are major, just imagining the financial, some of our friends are doing very detailed costing for HWCs, but imagining the financial demands to provide drugs and diagnostic for long-term NCDs, geriatric, mental health needs in such a vast population is a tremendous scale up and in the budgetary commitment. So there are big concerns of fiscal space. How do you work it? Of course, political economy, I can come back to it, but there is a critical component of strong community demand with a voice. None of the examples, country examples which I have said, has worked in isolation, keeping the community separate. So primary care is essentially at the heart of communities. So a strong community demand with a voice is a critical precondition. Political will is necessary, but not sufficient. What is more important is responsive, decentralized political agency, which gives the critical push to the success. Systems thinking and acting, we need more health system managers to recognize the linkages, and so it will require more cross-cutting broadband system reforms. But it's important that we are recognizing a health wellness center. Ayushman Bharat promises a vehicle to move into it, but whether it takes it to the desired direction or is again fails to deliver, its promise remains to be seen. Thank you very much for being patient and for any questions or any feedback. My email is there and I'm also in Twitter, so please let me know and I'll be happy to. Thank you very much for being patient.
Thank you, Sumit, for the great presentation. We have Dr. Sisir Debnath. He's a faculty at IIT Delhi, and his research areas actually span education, health, gender. I'm glad that we actually ended on the note of Ayushman Bharat, because Sisir has actually looked at Arogyashree program in Andhra Pradesh, which is a publicly financed insurance scheme. So off to you, Sisir. You have around 10-15 minutes. If you can wrap up in that time.
Sure, thanks Prachi, and thank you Sumit for a very nice overview of the primary healthcare in India with some examples from abroad as well. So it's very difficult to summarize or discuss primary healthcare scenario or Ayushman Bharat in 15 minutes, but I'll try my best. So, my work takes me to rural parts of India quite often. And if you ask this basic question, who is the hardest working primary health care? And in many parts of India, the unanimous answer that you will get is ASHA worker. And and if you don't have to be trained in economics or health or any other discipline, but if you look very carefully, why is it so? You can come to the answer. It's because of the salary structure. They are not salaried employed. That doesn't mean that they don't get any money. They actually get paid on the basis of the work they do. So their salary is basically the everything what they do. There is a fixed payment for each and every service that they provide, and their income is determined by how much you have worked. So if you think about, some basic of healthcare, I'm just trying to summarize what Sumit just said. You can be a very, very generous government, and you can both finance and provide. So that would be the primary healthcare center in India. The government is financing, because ideally you should not be spending anything if you are visiting primary healthcare centers or sub-centers. And it is also providing. So it's not taking help of any private sector to provide these. These are all government employees, more or less, through which these services are provided. Then it could be that the government is simply financing, they are not providing it. And a classic example would be the tertiary sector, in which direction we are moving right now. The government has realized, well, I cannot provide the services. I'm really bad at that. So let's just take help from private providers, and let me instead just finance it. So if you need a tertiary service, just go to a tertiary service provider. I don't care whether it's public or private. I'll just reimburse you or the hospital for the bills that are there. So that's particularly, in a nutshell, what Ayushman Bharat is. It's basically the government is saying that we have realized our provision is not as good. We do not want to get into business of provision, but we will simply finance. And you can be as stringent as Singapore government, where the government says, well, a certain part of your salary has to be saved for medical emergencies. They have a MediSave account. And if you don't spend on healthcare, you cannot spend on anything else. So we are not there yet. But in primary healthcare, Indian government is very generous. It has attempted to both finance and provide. It attempted to do it for tertiary sector as well, but over time it has realized that provision is not my cup of tea. Let me step back out of it. I'm just going to finance it. And the big ticket item that we all know that government floated is, idea that they floated is Ayushman Bharat, which is basically a trust-based, we should not call it health insurance, it's rather reimbursement of health costs to the providers directly. So I am not limiting my discussion to primary health care, because I will, Sumit summarized it so nicely, I don't want to talk about it. But before we move into a discussion of very roughly what Ayushman Bharat is attempting to doing, what are the key issues there. As I said earlier, the way you pay the provider is very crucial in determining the quality of healthcare that people will get. It is very surprising that in India, in pen and paper, healthcare is supposed to be free, yet the out-of-pocket expenditure is so high. Isn't that a real, puzzle? Why is it that our out-of-pocket expenditure is so high, despite the government is actually providing for it? The reason is quality. And you don't have to, just read through some literature and you will figure out, academicians has been screaming, for a long, long time, the main reason is just quality. Even if, and it has been almost means tested, even if nobody is barred from accessing it, the service quality is so poor, people do not generally go there unless they are absolutely forced to go there. And there's a very nice paper by Jishnu Das who actually show that quality of care actually are different for the same provider in the public setting compared to his own private setting. So they sent standardized patients, but I don't want to discuss the paper. If you're interested, go ahead and read Jishnu Das's paper. Very nice. Jishnu and Karthik, if I remember correctly. Yeah. So it, more than prices, I think the quality of care that matters. And unfortunately, the way our healthcare providers are paid, quality does not enter the equation. None of us ask the quality of care provided by a medical officer or A&M or any other provider before we decide their salary. So if you make their payment devoid of any measurement of quality, what you get is the worst possible quality. That's what happened. And I don't think this HWC actually accounts for that. Typically, the idea is if you get something for free, we attach, there is a stigma that get attached to that services. If you get drugs for free, what will be the idea? Well, since these drugs are free, they don't work. And the idea is, one of the reasons that I have learned across while I was traveling is that why is so many people push these antibiotics? Because patients want results. I mean, quality for them is quick healing. How do you heal them quickly? Push antibiotics, right? That's what quacks do. It's demand driven. They push antibiotics because patients do want, unless you have put saline on a patient, the care is not good enough, right? So it's demand driven, and unless SWC really addresses quality, it is not going to happen. People are not going to come back to the private providers. Now, then you have to measure quality. That is a completely different ballgame altogether. Measuring quality of healthcare is a different stream in itself. And different countries have attempted to measure quality of care. It's very, very difficult. We have no data on even measuring some very basic outcomes either. If you want real-time data on immunization, good luck. If you want any data on someone, the health-related data for someone above 5 years of age, good luck to you. So we don't have, real-time measures of basic healthcare. Unless you get to some detail about measuring quality, it is not going to work. Britain had tried to move to that direction. I think it's QOF that they implemented, which, there are some studies which show that they have eliminated some of the variation in services that were provided. Brazil is trying to measure quality through primary healthcare centers. So unless you are measuring quality, unless you are making their income of the providers a function of the quality that is being provided, I don't think anything is game changing here. We're just putting more money to it. I don't know, it will be just lost into the system. The other thing is coming back to tertiary care. So tertiary care, Ayushman Bharat is, I feel that it's given the shift in the burden of diseases towards non-communicable diseases. It's something that we had to do. If the government is not providing it, they ought to be financing it. But the real issue, I feel, is the reimbursement rates above anything else. So, when a hospital performs a procedure on someone who is a beneficiary for Ayushman Bharat, the government reimburses that hospital for the procedure that was performed. Now, what is the rate of reimbursement? That is probably the biggest bone of contention. Because if you set reimbursement rates too low, what is going to happen is none of the hospitals would be willing to participate in that program. They will say, we do not make any money, we are not going to provide any services. Now, if you set it too high, I don't think I need to say what is going to happen. If you set up appendectomy rates too high, suddenly you will see a lot of appendectomy patients. I mean, it's not in India, it has happened everywhere else as well. This is called upcoding in the US. So they have a Medicare system as well, and the moment a service is, the reimbursement rates are high, suddenly you see a lot of patients being upcoded towards those services and everything. So I don't know the answer to that question, what should be the optimum reimbursement rate, but the reimbursement rate should be variable. You cannot have a reimbursement rate which is fixed over time. There should be some formula, and reimbursement rate should also vary with the quality of the care that has been provided. Otherwise, you would not have all types of hospitals. If you provide the same rate, a very minimum rate, what will happen? Only probably the lowest quality type providers will enroll themselves, and the good quality providers, because their cost of provision is so high, they are going to keep themselves out of the system, which will overall downgrade the quality of tertiary care provided through Ayushman Bharat, and will kill, basically it will become poor service because poor hospitals enrolled themselves into the program. There is no quick answer to that question. We are trying to do some research what could be an optimum reimbursement rates. This is a very preliminary stage. We don't want to discuss the results either because it's so preliminary. But I feel that is one thing that the government needs to nail down before doing anything else. And we don't need to, start from scratch. There are similar programs that has been implemented by various other states, particularly some southern states. We did study Arogyasri program, and several things came out. This is not a platform to discuss those results, but the reason we could do those studies, the reason we could figure out, well, we can even think of questions like what could be the reimbursement, optimal reimbursement rates, because the data was publicly available. So we need to have serious research in here. We need to ask this question, well, this system was running for so long, can we use this data in a way to figure out reimbursement rates? Can we really have co-payment rates? I mean, we all talk about Medicare, Medicaid, but many people do not know. Actually, there was a huge experiment done, one of the largest experiment in the history of social sciences, which is the RAND healthcare experiment, where the co-payment rates were varied for different households to figure out what is the effect of co-payment rates on healthcare utilization. We are at a very similar stage. We are, this happened in the US in 1960s. We are also about to formally, we have rolled out, but it hasn't really taken, full steam. But we should be doing these experiments to figure out the reimbursement rate. We should be, doing these experiments to figure out whether there should be no co-payment at all, there should be 2%, 5%, what is the optimal rate. We should be trying to measure quality of care, make salaries functions of the quality of care that they're providing. Without this, I don't think these are game changers. More money put into this existing system, which, like many other government programs, will be called, well, the intention was well, but the implementation was poor. So I'll just stop here. But we welcome questions from the audience, and I guess Sumit will be happy to take them.
Thank you. Thank you for such great comments.